Good morning. First of all, Dr. Cüneyd, Dr. Mesut, thank you very much for your kind words at the beginning of this session. And as chairman of the European section of Function and Female Urology, I am very much honored to be invited to give a lecture here. Also, as chairman of the section, I want to invite you to attend the section meeting and the entire EAU meeting next year in Amsterdam, face to face. Hopefully, we'll see. Well, I was invited to talk about underactive bladder definition and management. And this is an interesting topic. These are my disclosures. Because underactive bladder and the Cruz'un underactivity are frequently used with the same, the intention of the same meaning, but they are two faces of the same coin. Underactive bladder is the symptom complex, defined according to Chris Chappell as a symptom complex with hesitancy, reduced sensation of bladder filling, slow stream, prolonged urination time, with or without a sensation of incomplete bladder emptying. While the Cruz'un underactivity should be the urodynamic counterpart of this problem. So it is a contraction of reduced strength or duration resulting in prolonged bladder emptying and or failure to achieve complete bladder emptying within a normal time span. Of course, after reading this, we all will agree that these definitions are not perfect. We don't know exactly what is a prolonged urination time. We don't know what is a normal time span to empty the bladder. So these are definitions that will change in the future, but they are at this moment useful for working on this topic. So let's talk about the symptom complex, underactive bladder symptoms, and which are the typical symptoms we might see in a patient with this problem. And this study compared patients with lower urinary tract symptoms that did pressure flow studies and those that had the Cruz'un underactivity and those that had a normal urodynamic study were compared. And the symptoms, both for males and females, are weak stream, interrupted stream, hesitancy, straining to void, decreased sensation for bladder filling, and incomplete emptying, the sensation of incomplete emptying. Those are the symptoms that better differentiate patients that have the Cruz'un underactivity and those that have a normal pressure flow study. Well, but this is an incomplete view of the problem. These are data from a survey in the United States. The survey was sent to people above 60 years of age, and the questions to identify patients with underactive bladder were: do you strain to void? Do you have difficulty for emptied bladder, or do you have episodes of urinary retention? And so people were grouped in 4 different groups, let's say, with 0 symptoms or up to 3 symptoms. And what was observed was that storage symptoms were also extremely frequent in these patients. Those that had 2 or 3 symptoms or 3 categories in the survey, 2 or 3 positive responses in the survey, had a high prevalence of nocturia, of urgency and frequency, like 70, 80, even 90%. So one has to understand that a patient with underactive bladder might also appear to us with intense storage symptoms, and that makes the diagnosis more complicated. So let's say that facing a patient with underactive bladder, we have to be extremely careful and have a high degree of suspicion because, well, we might have the voiding symptoms, hesitancy, weak stream, interrupted stream, straining to void. We might have the decreased sensation of bladder filling, incomplete bladder emptying, but also frequency, nocturia, urgency, and eventually incontinence at night. So it is, from the clinical point of view, a very complex symptomatic situation. The TRUSR underactivity, the urodynamic counterpart, is essentially based on pressure flow study. And pressure flow studies are invasive studies, and according to different cutoffs for PDET, Qmax, and for the flow, the prevalence of the TRUSR underactivity may range between 10% up to almost 50%. Of course, these are tests that are not easy to perform every day, and clearly, for clinical practice, we need something more easy to perform. And I like this study. It was performed in Korea and compared almost 4,000 examinations, urodynamic examinations, and compared different forms of diagnosing the TRUSR underactivity. For example, compared to pressure flow study in males on the left side, a bladder contractility index is not useful because overestimates the prevalence of the TRUSR underactivity. And bladder voiding efficiency, which is a non-invasive method, is not too bad in males. As they say, less than 90% for bladder voiding efficiency distinguishes differences in age and Qmax in males with the TRUSR underactivity. But in females on the right side, the correlation between the two is extremely good. And so bladder voiding efficiency below 90% might be a non-invasive method to quickly investigate if the symptoms of our patients are due to the TRUSR underactivity, because, as you know, it is only based on bladder, on the voided volume and on post-void residual, which can be measured, of course, without invasive methods. This is particularly useful in some conditions that we know that are associated with the underactive bladder and the TRUSR underactivity, the diabetic cystopathy. Everybody looks into nephropathy and retinopathy in these patients, but 80 to 9% of these patients will have, diabetic patients, will have cystopathy, which is characterized by the TRUSR underactivity. And if we have to follow up these patients and to investigate the degree of the TRUSR underactivity, clearly the best method should be non-invasive, and you see that PVR and bladder voiding efficiency in this study has a good correlation with the situation of the TRUSR underactivity. Of course, there are other methods under investigation, but back again. Sorry. The TRUSR wall thickness was investigated in Netherlands, but if you remember, the TRUSR wall thickness was not very useful for the TRUSR overactivity. And I am sure that measuring bladder wall thicknesses or the trouser wall thicknesses of 1 millimeter or 1.2 millimeters will be extremely difficult for the general urologists and radiologists, and I don't think it will be very useful for the future. Scores. This is a Japanese proposal, and it might be interesting for males. This score is based on the age, on the prostate volume, on IPSS, based on the question about urgency and on the question about weak stream, and on the flow. And if you look to the right, if a patient has a score of 11, that patient, that male, will have a probability of having the trouser underactivity of 90%. So let's see if this simple score applied in multiple centers might be useful or not. Eventually, in the future, we might use genomics, but because we know that bladder outlet obstruction will cause stress in smooth muscle fibers, and that will cause the expression of some genes. And in biopsies carried out in patients with bladder outlet obstruction, investigating mRNA and microRNAs, it is possible to see that for reasons we don't know exactly, some patients will express genes that lead to the trouser underactivity. They appear in yellow on the right side, while some patients express genes that induce the trouser underactivity, and others do not express neither one nor the other. So eventually we might use mRNAs and microRNAs, genomics, to predict the future of patients that have bladder outlet obstruction. Well, in the last 5 minutes, I want to address the management, which, of course, at this moment, I must say, is still in its infancy, is still very poor. But I think the first message we should give to our patients is that the trouser underactivity or underactive bladder is not a dramatic situation. In this study, 50 or 69 patients actually were followed up during 10 years. And after 10 years, only 15% had to be submitted to QRP due to acute urinary retention or very severe lower urinary tract symptoms. The others remained quite well. And on the right side, comparing urodynamic parameters at baseline and after 10 years, you can see that PVR, bladder voiding efficiency, PDAT-Q max, and maximal systematic capacity were similar. And in terms of severity of symptoms, frequency, nocturia, reduced stream, and hesitancy have equivalent severity from baseline to 10 years of follow-up. So this is an important message. We don't have to rush to treat the majority of our patients. We need to follow them and so do what is called watchful waiting. And that is safe. What about prostatectomy? It is usually considered that patients with the trouser underactivity might not respond well to prostatectomy. Well, apparently this is not entirely correct. Some bladders might be able to recover their capacity to contract. And in this study, patients with the trouser underactivity after prostatectomy even those that had a low bladder contractility index, so below 100, almost 80%, meaning 4 out of 5 were able to resume spontaneous voidings with a reasonable Qmax, not so good as patients with a very good bladder contractility index, but never mind, they were voiding spontaneously with good voided volumes and a reasonable PVR. So, after a full discussion with our patients, I think we might offer prostatectomy with a high probability of success to patients that have the Cruz'un underactivity caused by bladder outlet obstruction. Sacral neuromodulation might be used, and this Maastricht Hanover normogram based on the Watts factor and on bladder outlet obstruction index shows that sacral neuromodulation might be useful, but not in all patients. If the patients, according to this normogram, are below the 10th percentile, they will not respond to sacral neuromodulation. Those that respond better are between the percentile 25 and the percentile 10. Yesterday we spoke a little bit about the urethra, and these are experiments that we carried on in our own lab in rats, comparing young rats and age 24 months of age rats, which are very old. And the red dots are neuroendocrine cells that express serotonin, and you can see the decrease from young to elderly animals, a substantial decrease in the number of these cells. And in old animals that had the Cruz'un underactivity in the cystometogram, no contractions at all in the lower part on the left, the irrigation of the urethra with serotonin, a solution containing serotonin, which of course was missing because the number of neuroendocrine cells was decreased, was able to cause bladder contractions and actually to improve bladder voiding efficiency in the animals. So eventually in the future we might need to test the neuroendocrine process to reactivate the urethral bladder reflex. Stem cell therapy might be also a solution in the future, and in this experimental study in diabetic rats, stem cells improve micturition pressure and bladder voiding efficiency in these animals, and also the expression of some genes. But the stem cell therapy was already transferred, translational research is this, into humans. And in this pilot study, which was recently published, one can see that after 2 shots of stem cells derived from the quadriceps femoris from the patient, injected at 2 different occasions. Well, we don't have all the patients at 1 year of follow-up, but if you look on the left side to the blue dots, some of patients improved, which is better than nothing. And on the right side, you can see the bladder voiding efficiency, and at least, let's say, in 50% of the patients available at 1 year, the bladder voiding efficiency improved substantially. So, as conclusion, we have to understand that underactive bladder is a symptom complex, and the Cruz'un underactivity is an urodynamic finding, and we need clearly to fine-tune the definitions. Although voiding symptoms might predominate, we should keep in mind that storage symptoms are extremely frequent in the underactive bladder symptom complex. We need non-invasive methods to detect the true surrender activity when we suspect that the LUTs in our patients are due to the true surrender activity. And we need to do much more research to find effective treatments for this condition. Thank you very much for the invitation and for your attention.